Hello, my name is Badru Ssenoga. I'm here to present interpretable drug resistance prediction for patients on antiretroviral therapies, in brief ART. I worked with Jacob on this project, and I'm here to present to you this. So some of the things that we are going to look at. So in brief, HIV, a human immune virus, is the pathogen that causes AIDS, that's acquired immunodeficiency syndrome, an incurable disease that affects our immune system as humans. So one of the ways to control the spread of this disease in your body is adhering to ARVs, taking your ARVs in time, and that is for all the patients that are already on treatment, and being able to ensure that these drugs are able to work, the ARVs, the ART, for it to work, the treatment to be working, you need to be adhering to drugs, taking it in time, at the right amount. You don't miss any time that you're supposed to take the drugs, and you don't forget. So it has to be routine testing also that needs to be done through viral load tests to ensure that yes, you're taking your drugs, but is it responding? Is your body responding to the drugs that you're taking? And in case it doesn't, then we can go ahead and intervene to detect the drug resistance to the treatment that you're taking. So these are some of the variables that we have in our data set that we are using. It's a data set from Uganda, and we have good variables or features that we looked at, such as ARVs adherence, whereby you can see who is the patient adhering to the drugs and those that are not. Then result alphanumeric, which shows the amount of the virus, the HIV, in your blood per milliliter. So it is a very good feature as well. And then suppressed, it shows whether your body is responding to treatment or not. So if it is suppressed, it will show a 1 in the data that we are using. Then if it is not, that's when you'll be able to see, you can see a 2, a 3, meaning you could be somewhere lacking in terms of adhering to ARVs, that is for the patient. Then we also have another good variable, that is current regimen, which shows the treatment that this patient is on, as well as treatment duration, the age of that patient. So we shall be using the different variables. So what we need to do today is we need to track the patients on treatment that are more likely to change from one treatment line, let's say the first treatment line, and we want to predict them if they are to go to another treatment line. Who are those patients that are more likely to change from one treatment line to another treatment line? Usually it happens between 2 to 3 years, but when you do the prediction, it helps us easily identify those patients and be able to remind them, so that in the long run we are able to reduce on the cost of ART treatment. It also helps us with our health system as a nation, and it also helps in the overall fight against HIV AIDS in Uganda. So there was an ML application that did predict the HIV status, especially in men having sex with men. You realize it is one of those groups that are usually excluded from traditional testing due to stigma or legal issues. So it was more about the predictors for HIV test, but in a way it is related to some of what we are going to be showcasing. So one of the objectives is to efficiently and effectively tackle the challenges associated with the small data set, whereby previously there are some data sets that were used, but there are features that were not available, and we believe these extra features that we have in our data set will be very helpful in helping us get more accurate results, and that according to different algorithms that we are going to use. To also ensure good generalizability and adopting the algorithm within a proven nonlinear method that will help us get exceptional results. So we shall be comparing the different results from the different algorithms that we are going to be using with this data set. Briefly, that is how the data set is. It is having these are some of the variables that we are looking at. So methodology, we use 2019 data, that is the data set we used, and we simply did the data processing and feature selection, whereby we are able to go ahead and identify which features are more important when it comes to what we want to achieve at the end of the day. Then we're able to split this data into training data, that is 70%, and testing data, which is 30%. Thereafter, we're able to instantiate the model, that is KNN, DT, that is decision tree, random forest, linguistic regression, then GNB, that is Bayesian naive Bayes. Then after that, we're able to do the model evaluation, whereby we find out the different F1 score, model HSC, then we find out the precision, we compare them, the different results that we get. Then after that, we shall be able to find out which algorithm performed well. And at the end of it all, we need to do the explainability. We used Lime and Sharp to be able to remove that black box thing whereby you know the results or you get to know the prediction, but you can't explain it. So we want, at the end of the day, it is better to have a model that is understandable by a human being, and that creates trust while using the model, and even the results, you can clearly defend them, or you can understand where they are coming from. So these are the algorithms that we have used, that we have used with the data set that we are having. So heat map is simply showing a correlation between the different variables, and that is between a range of -1 and 1. So realize that an increase in suppression, if you see suppressed, an increase in suppression, it reduces the result alphanumeric. It reduces the viral load of that patient. When you compare those two variables, when suppression increases, the viral load reduces. The result alphanumeric, that is the one that represents the patient viral load, it reduces. So that is why we are having -0.7. So we realize that the more the value tends to 1, it means there is it correlates positively. There is a linear relationship or trend between the different variables. So box plot simply shows the current regimen on the y-axis, the treatment level, and then the x-axis is where we have suppressed, which shows number 1, it shows the patients that are suppressing or that are responding well to treatment, and you can clearly see that they are intact. They are they are all intact. There is no separation, or which shows that they are responding to treatment, meaning they are adhering to ARVs. Then patients on number 2, these are responding fairly. You see they are trying, but there is some gaps, meaning there are some few that are not adhering as they should. Then number 3, it shows that they are Badru. There is these particular patients, they are Badru. You can see outliers, like they are not adhering to treatment as they should. So after getting our results, we were able to use the explainable AI. That is the one that we first used is the local interpretable module agnostic explanation, which showed us that ARVs adherence, result alphanumeric, and of course indication for viral load testing. These are some of the best predictors that that can give us what we want when it comes to predicting those patients that are more likely to switch from the one treatment line to another, and realize that the treatment duration does not have any value when it comes to the Lyme explainable AI technique. Then realize that with Lyme, our predicted value, we have in the middle, as you see, that is 2. Still, it is emphasizing you can clearly see why is treatment duration on the left, and why on the left, meaning it is not of value when it comes to us predicting the patients. The features that we should put interest in, or which will give us what we want, they are on the right side, and you can even see their values. So it is explained, it breaks down for you why it is deciding that these are the best features for us to take. Instead of taking treatment duration, let us take ARVs adherence. And as well as this, we in our code, in our Jupyter notebook code, we created mean. We were able to create the mean, and we compare it with these results from Lyme. So when you realize that the value you're having here, let's say the value you're having here is less than the value you have in the mean, it shows it is on the negative, it is not contributing to what we want. But if it is more than the average, or it is more than the mean, sorry, it means that it is contributing to what we want, and that what we want is to find out the patients that are more likely to move from one treatment line to another in future, as long as we have these particular features. So here we are able to understand why the model is telling us this. We are able to break it down and be able to understand, and someone can have trust to use the model and even use other different datasets in future. Another one is the sharply addictive explanation, in brief sharp. Here we use a base value. We also have the option of the different features in our data set. You realize that ARV here for sharp, ARV adherence does not contribute, does not have value to what we want. But you see that result alphanumeric, it has a very big gap. It positively contributes, or it can help us be able to tell those patients. The same applies to treatment regimen and indication for viral load testing. So in brief, these are our results when we run the 5 machine learning models. Comparing their F1 score, you realize that DT, that is 0.9949, then there is the highest when it comes to the F1 score. Then even when you compare model accuracy, still it is the best. Even when you compare precision, recall. So in brief, with this, you can even tell the true negative, the patients that are responding to treatment, the way the model is showing or is predicting. Those ones that are not responding to treatment, like the way the model is showing, so that you can see the classification error, classification accuracy, true positives, true negatives, false positives, false negatives. All the results are summarized in this table. But realize the best performing algorithm was decision tree, because you can clearly see the F1 score is higher compared to the rest. So in conclusion, we have demonstrated that this is promising and it has potential, especially with the decision tree algorithm, and we believe that we can predict patients that are at a high risk of developing resistance during ART treatment. And I believe with more secondary laboratory data, we can go ahead and find better ways of improving this. But of course, we were limited by constraints of time and finance while while working on this project. For future works, we believe that we can capture additional predictors, including behavioral characteristics. Do you take smoke? Do you smoke or you don't smoke? Do you take alcohol? Do these things also affect the way whether this person will respond to treatment or not? So we will provide those more comprehensive understanding of the things that can cause drug resistance development in the patient population. We would like to thank Dr. Isaac Sewanyana at Central Public Health Laboratories, who helped us with the authorization to use this data set and also gave us guidance while coming up with this paper. Thank you very much.